Everyone, I'll start with a little introduction of myself while my slides get pulled up. My name's Anna Lynch, as Warren said, and I am a clinical research coordinator who works in Dr. Mussolino's lab. I've been in the lab for almost 3 years now, and I have been working on this project for about the same amount of time, for 3 years since I graduated college in 2022. Great, so as stated, I'm going to be talking about a quality of life patient and caregiver reporting outcome survey that was distributed over 2021 and 2022 to various MSMDS families. And specifically, we're focused on the Arginine 179 pathological variants. So a little bit about the patient cohort and our methodology to choosing subjects. The survey was first developed at MGH. We incorporated some disease-specific surveys that were created by physicians at MGH, as well as some NuroQOL surveys that are available to anybody free on the NIH toolkit website. So those are specifically pediatric surveys. And the survey included 69 questions. We have a varying number of systems that we talked about, the neurology, cardiology, pulmonology, the autonomic system, gastrointestinal system, urinary, ophthalmology, etc. And we had 44 patients who were initially interested in participating in the study and completed the survey. However, 9 of those patients were excluded due to not knowing their specific pathogenic variant, sorry. And patients who had a confirmed ACTA2 Arginine 179 mutation was 35 patients. We have 31 females and 4 males. As we can see, this is very heavy on the female side, not many male subjects. And we had 22 surveys that were fully completed, and then we had 13 surveys that were partially completed, missing about 2 of the last questions. So we did exclude those 2 questions from our analysis. So a little bit about our cohort. We had a median age of 8 years old at the time that the survey was taken, and we had a median age of diagnosis of about 3.7 years old. And a few of the larger time of event symptoms, we have that 34 subjects underwent PDA or APW repair, and the median age of that was about 2.5 months old, with 18 subjects also having at least 1 stroke, with the median age of first stroke around 3 years old. And then we had 5 subjects who had an aortic dissection, with many others having other aortic events as well, which I'll discuss in a few minutes. And I have these 2 graphs down here below. The first one shows the difference at the age of diagnosis with the Regalado paper, which is a well-known retrospective ACTA2 natural history paper that described the disease. So we see about a median age of diagnosis in that cohort at 11 years old. And then in our cohort, we see that 3.7-year-olds median age of diagnosis. So there's a significant difference between those 2 papers in only a 4-year time span. And then one of the questions that we asked participants was, what symptoms do you find the most challenging? What system is affecting your life the most? So we see that the neurological and cardiovascular symptoms are the most challenging. And then that is followed by pulmonology, very closely behind, autonomic, gastrointestinal, neurological, and then ophthalmology at the end. So beginning with the neurological outcomes that we found, we saw that patient-reported stroke incidence was higher than previously published ACTA2 Arginine 179H. So as we can see, the majority of patients in this graph on the left have had a stroke before 10 years of age. And the strokes varied from 1 stroke to upwards of 7 strokes. So you can see in the pie chart on the right, we had multiple patients who had had 7 or more strokes. And then this schematic was also in Dr. Lindsay's presentation, and he explained that very well of the vessels and how they are different in patients with Arginine 179. So in the Regalado et al. Paper, we only saw a 27% incidence of stroke. So ours is almost doubled with 51% of patients having strokes. And then 55% of those patients had recurrent strokes.
Before you advance, just a quick question on that graphic.
Mm-hmm.
So if I'm interpreting that correctly, you have nearly 100% risk of having a stroke after age 30 based on the cumulative risk?
Yes, that's what it is predicting based on the patient information that we gathered. Not all of our patients in the survey had a stroke, but with the analysis that it uses, that's what it is predicting, yeah. So next, I'm going to move on to seizures, and we see that more than half of patient-reported seizures resulted in hospitalizations. So we had a 37% incidence of seizures, with the most common seizure type being focal seizures. And we also see that the majority of those seizure activity starts before the age of 10. And then hospitalization was in 77% of patients who had seizures. And then we see some other side effects, which is the inability to attend school, increased anxiety of having another seizure, avoiding social interactions, and sedation from seizure medications. And then we had 11 out of our 13 subjects who reported a seizure had also reported a stroke at the same age of or after the time of stroke. But we did have 4 patients who reported seizure activity previous to stroke activity, suggesting other possible causes such as infection, white matter damage, or blood-brain barrier dysfunction. And then going into developmental delays, we saw developmental delays in the motor, cognitive, and language sphere in all patients in at least one of those spheres. It was reported. For the different domains, we're speaking and understanding language, fine motor, gross motor, gait function, age-appropriate social interactions, age-appropriate intellectual abilities, and attention. So in this graph on the left, the top axis is going to be average impact. We had subjects rank from mild, moderate to severe of the impact on their daily life. So 1 is going to be mild, 2 moderate, 3 severe. And then the milestone prevalence at the bottom is the percent of subjects who indicated that they had that milestone delay. So we see the greatest average impact for age-appropriate social interactions, and we see the greatest prevalence for fine motor control. And then I wanted to see if having a stroke or not having a stroke would lead to a greater number of milestone delays. So on the graph to the right, we have the blue is having a stroke and the white bar is those who had not had a stroke. And we didn't see any significant difference in the number of milestone delays between the two groups. So that means that there is most likely another cause for milestone delays other than having a stroke early in life. Moving on to some of the cardiovascular outcomes that we saw. All patients reported having a PDA or an APW at birth. 1 was unsure of the type of defect that they had. And there was also some post-surgical complications to fixing those, as I said earlier. The median age of PDA repair was 2.5 months of age. So we see complications for over 50% of patients, with prolonged respiratory distress being the most prevalent. And then there are other aortic events, as I mentioned earlier, that we had 5 patients who had had dissections, but we see a majority of patients who have had aortic dilations, and then another. Then we also see aortic replacement or grafts having to be done when patients are typically older. And then for pulmonary outcomes, although the majority of patients reported that they have normal oxygen saturation levels above 90% when just taken on a typical day, we did see that the majority of subjects require supplemental oxygen within the year. So we asked how many typical days within a year do you require supplemental oxygen? So we have ranging from just one day to or a couple of days within a year to some patients needing to be on oxygen year round or almost year round. And then here's where some of the NuroQOL questions come in. There is a physical activity NuroQOL as well as like a pulmonary function NuroQOL. So we can see the pulmonary distress highlighted in these questions and the answers. So the first question was, my illness made it hard for me to breathe. And we can see that over half of the subjects responded strongly agree. And then on this graph down below, I highlighted 2 questions for exercise intolerance. Were you able to play sports for greater than 10 minutes? Were you able to run for greater than 10 minutes? And this is just in a typical week. And majority of patients said no days or 1 day, upwards of 75 to 90% of those patients. And then moving on to urinary and gastrointestinal outcomes, we see that constipation also takes a great toll on the quality of life of these patients. Some reporting it to affect their quality of life every day, weekly, monthly, a few times a year, and the not really affecting their quality of life is a smaller percentage. Only about a quarter of the patients are affected by gastrointestinal complications. And then for urinary issues, we see a large portion, almost 60% of patients saying that they experience a urinary complication within their life. Retention being a main one. This is often combated with catheterization, either a permanent cath or intermittent. And then we see incontinence, urinary tract infections, pain when urinating, and then other complications as well that were unspecified. We also looked into the use of a G-tube or J-tube and how it is often associated with being diagnosed with failure to thrive. So we see that a majority of patients did not require a G-tube or J-tube, but we see that those who did have a greater proportion on this right graph, have a greater proportion of being diagnosed with failure to thrive, 11 out of 15 rather than 6 out of 20. So over half of the patients who did have a G or J-tube were diagnosed previously with failure to thrive. We also have 2 different types of G or J tubes that are used. On this graph on the left, we can see that 6 use a temporary G or J tube, and the remaining 9 use a permanent G or J tube. So there are some limitations to our study. First one is recall bias, that not all information may be remembered correctly, especially some of the more distant memories for some of the older patients specifically. And then we also have survey fatigue. We may have lower inaccurate responses, low response rates towards the end of the survey, just due to trying all the energy exerted at the beginning. So we did exclude those data points from our survey. It was the last 2 questions, as I mentioned earlier. And then also, as I mentioned, we do have a disproportionate amount of females to males within the study, potentially decreasing the generalizability of our findings to the male population. Then a few conclusions. We more deeply characterize some of the well-known symptomology of the disease, such as strokes, seizures, PDAs, APWs, and dissections. But we did see an almost doubled incidence of strokes and seizures to previous reports. As I said, one of the main retrospective natural history papers only saw 27% prevalence of stroke, and we saw a 51% prevalence. The general pediatric population only has about a 19% seizure occurrence, and we saw a 37% seizure occurrence. And then we also saw developmental delays in all patients. That same paper only saw 19% of their population had developmental delays. So that was a significant difference for our paper. And then PDA, APW, that was consistent with other published records that all patients or almost all patients are born with a PDA or APW and get it fixed within first year of life typically. And then we also saw a greater number of patients who had exercise intolerance, significantly affecting their quality of life. And a great thing today is that adaptive sports are really gaining in popularity to get kids involved with the community and to build bonds and make friendships that way if they can't do so due to their exercise intolerance in a school setting or general sports. I also didn't show a graph for this, but we did see that autonomic thermodysregulation that has not been reported yet for ACTA2. It was identified in our cohort. What this means is that patients don't respond to temperature changes well. From hot to cold or cold to hot, they have difficulty. And then we also saw, as I mentioned, the assistance of a G or J tube for nutrition developed as a novel observation. And then I didn't mention this yet either, but congenital mydriasis, which most of you probably know about, can be identified as birth. That is the fixed dilated pupils. So therefore, that could be added to the universal newborn test eye screening because it's a non-invasive means of early diagnosis and the ability to start preventative care sooner. And also my contact information is down there if anybody has any questions. And then I just have some acknowledgements for Dr. Mussolino and Dr. Lindsay and the labs and others help and support with this research, as well as the ACTA2 Alliance, specifically Dixie, Warren, and Penny for helping distribute this survey when it was first developed and helping develop it as well. And then the whole vascular gene therapy team for their research in ACTA2. And then a special thanks to Dr. Mussolino for all her work with me on this paper and research. And then Rebecca Oberman as well for all her work that she does with rare diseases and helping to get this paper, to get this survey out when it was out. Thank you.
Do we have any questions for Anna?
I'm wondering if you could speculate a little bit, given that some of the patients don't present or detect the disease till they're in their teens or maybe a little later, what your thoughts are on the percentage of non-diagnosed patient population that might be out there?
I think what we might be able to see from this with our large majority of females, that maybe there could be a large male population that is undiagnosed. Since it is a de novo mutation, it should be approximately 50-50 with the number of subjects, male and female. So we could see either a more severe presentation for males or a severe presentation for females, and that might be the reason why one is getting diagnosed over the other.
The other question I have is related to the fact that it seems like there are clusters of patients in more Western areas, the US and in Europe. I'm just wondering your thoughts on sort of the overall percentage of the population that might have the disease.
Yeah, so within this survey, we had 9 countries, subjects from 9 countries who were involved, and you are right, they were mainly US and Europe. It could just be general access to information, access to care, access to being able to reach out to the foundation or knowing about it, or just other people in your area who have it. Yeah, Dr. Mussolino can definitely say more.
I was gonna put the question to Diana. So I think who has the best data and information and has been studied the genetics and the incidence and everything, and there's an effort in California, I don't know if it's taken off the ground, on doing whole exome sequencing in newborn screening patients to see really that question, what is the real incidence of this particular variant, Arginine 179, but other variants also in the ACTA2 gene. So I think we should post this question, just remember it to when we have Diana, because I think she has information and data that might have not even been published that is very relevant. But we suspect there is a lot of patients not diagnosed that are hopping between different care, including getting the aortic replacements or being diagnosed with moya and not being yet known to have aortic disease. From the teenage diagnosis, they're mostly being diagnosed for the aortic care, and because they have to get a replacement, and sometimes they even go through the whole surgical procedures without brain imaging. So they don't even have the two dots to be combined. If someone doesn't say after anesthesia, oh, the pupils are fixed, dilated, the patient is herniating, then that's when the things may get connected. But it's very easy to not have the syndrome in front of you as the subspecialist, and they're just dealing with the complications. And that's what we hear from the families with late diagnosis. They bounced around getting care and good care for each aspect of the disease that nobody had put it together. And then we have parents that they did their Google stuff and they told the physicians, hey, I think this is a gene we should be testing. I think half of the room here probably is in that position. But yeah, we suspect it's a large population of.
I wonder if you could look at what percentage of the population has the hydriasis versus which ones have
Oh.
ACTA2.
Yes.
That's very easy as a surrogate to look at.
Absolutely. And in fact, I keep saying this, and I want to make you, the advocacy groups, responsible for this, because we need to move this along. When a newborn gets out of the hospital, you have to check if he's born in the hospital. You have to check an exam. It's a newborn exam. It's recommended by the American Academy of Pediatrics, and it includes shining a light in the baby's eye. Every single newborn born in almost every country, okay, gets a light shine in the eye to see if they have cataracts. No, so if there is no reflex, red reflex we call it, you diagnose them with cataracts and you just refer them to ophthalmology. That's what the pediatrician that is about to discharge the baby has to do. We need to advocate to add to that exam a second checkbox that says, does the pupil constrict? Okay, so to do this right, there is a study that is needed, and we've been working with Dr. Lynch and other people in the neonatal ICU to run a pilot at MGH. We have around 40 births between the Brigham and MGH per day. So we think if we ask our 2 newborn units to check the mark, we will find out if there is an increased detection of false positive, meaning they say the pupils don't constrict, but that's because baby pupils are very large and it's hard to assess them. And if that's the case, then we have a problem, because people are going to be referring tons of babies to ophthalmology when there's no need to do that. But we do have to advocate to do the research to see if assessing the pupils at birth by just adding a check mark. We're not talking about blood, a test, Congress, newborn screening. We're not talking about any of that. It's a much simpler task. But we have to show that a clinician can do it. And when they find that the pupil doesn't constrict, what comes next, which is ophthalmology and an echocardiogram, because we want to make sure they check for PDA, no? These babies need to be repaired. Is happening, and what does it look like? If there is a lot of false positives, then we will have to think about another way to detect the babies. But I cannot agree more that we have a low hanging fruit here for diagnosis, very early diagnosis.
So just to clarify, you're talking about adding it to the APGAR scoring.
It's not an APGAR. APGAR doesn't include pupil.
But they look at the eyes when they do APGAR.
It's not on the APGAR. No, it doesn't have anything on the APGAR. We don't have to score eyes. What happens is before the baby leaves the hospital, there is what is called a newborn exam.
Yeah.
And it's just documented in the discharge. And usually it's a little form that the pediatrician in Epic or whatever. Let's add to the red reflex, do pupillary constriction exist? That's what I think is possible. I don't know.
So you're not talking about officially adding it to the newborn screen with hearing testing or pulse ox?
I have an
Okay.
example.
Yeah.
I think Dr. Lindsay is in clinic. He had out of state patients, so he couldn't be here, and the patients are coming from very far away. They've done this for congenital heart disease with cyanosis. You know that babies that are born with large congenital heart disease can be blue. So they did the same work. It's a physical examination to be added as a recommended screening at a newborn. The newborn screening is usually the blood test and
But also the pulse ox and the hearing test is like.
yeah,
officially
clinical. Yeah.
recommended by the advisory council for newborn screening.
Yeah, and ideally we get there, but I think we have to do the research to show the same way that they did it. Like you have cyanosis, can make the clinician tell the baby is blue reliably, and how many times they're right or wrong, and then what happens next, and how many of those exams that you order, like let's say an echo, to lead to a diagnosis of congenital heart disease. They had to do that study to be able to show that clinicians can detect blue babies, and that echoes tend to be positive for congenital heart disease when this is coming. So I think we have to do that, and then with that data, then you can advocate for including in the more federal, whenever the committee exists again.
Yeah, exactly. That's what I was gonna say.
It's been, for those that don't know, the committee that review with all the experts, volunteers, by the way, this didn't cut any money for anybody. That review the recommendations and recommended a disease, a rare disease, to be added to the federal newborn screening, has been terminated in April something, with no communications or anything, and we don't know when is it going to be reinstated and how, and if it's going to be state-based. It's going to be almost impossible for the states to do this. There's too many experts that you need to bring in.
I think they too.
Yeah.
Look it up, but
Yeah, it's
ridiculous.
it's among the things that are being advocated at the Hill for this reconciliation thing.
Hi, I'm Heather. You guys don't know me, well, Patty does, but I'm a gene therapy person who collaborates with Patty on this really important project. From a different disease perspective, we're looking to add 3 diseases to newborn screening list. And we were, working through the process and all of the things, trying to get it on the RUSP and all of it, this and that and the other. And one thing we've kind of all put our heads together with is the frequency of exome sequencing is like rapidly becoming higher and higher and higher and higher, and less expensive and less challenging. And so there is something at Boston Children's right now that's a sequencing panel that you can get added to by just sending an email. And so I think it's not quite a pilot, but it gets around.
sorry.
It gets around some of the other stuff, and so I would recommend you guys do that. And I hate to say this, but I would probably not prioritize the newborn screening thing right now, because it just seems to be like a dead duck. And we probably need to work with, so there's some, sit on the Massachusetts Rare Disease Advisory Council, and we were discussing, how are we going to handle this issue as a state? And I think that a role for our newborn screening lab here will be a big one. And so that's something you could consider reaching out to and talking to them. But I would get on this thing that's at Boston Children's. I'll send you the information. Because I think all you have to do is to start hounding Wendy, Sean, and she will put you on there, as I understand it.
I just one other thought. I just double checked. I don't remember how long Actitude's been on the secondary findings for exome. But that we might be able to go to like GeneDx and ask how many times they've had, like, it wasn't a referral for exome that had to do specifically with Actitude that they found a change or found this change. That would be an easy thing to do in data that exists.
Yeah. We should revisit. We asked this question 3 years ago.
Okay.
and they didn't have data other than what they have in the aortic, thoracic, familial aneurysm panels, and not the exome.
Okay,
So
do you know
but
how long it's been on?
they promised us to do to look into their database. They have like 700,000 exomes now. Like it's really large cohort. And you can request these things and they can do it, but we haven't followed up with them. It was Santoro from UCLA that was requesting for all genetic vasculopathies of Moyamoya disease. And we got from some of them NF1 and stuff like that data, but we didn't get anything from ACTA2. But it's almost 3 years ago, so we should revisit. It's a really good idea, just to start understanding how many times.
I guess, Cheryl, so I have a question about, Anna, about your, data. You had said, I don't remember what the number was, but it was, I think Seth pointed it out, that the patients are expected to have a stroke after the age of 30 based on that data.
So we had 18 patients who had strokes at all different ages. Each of those like little steps that you saw in the graph would indicate a stroke or multiple patients who had strokes at that age. So with those 18 patients, it's seeing those as a cohort. We do put the ones in who didn't have a stroke as well.
But Anna,
So
the data doesn't show
It
that
doesn't-
strokes happen after
No.
30. The other way around, the data shows that most of the strokes are happening before
Early.
10 years of age. Okay, so all the steps, the climbing is happening really soon. Okay, so it's happening in the first 10 years of age, less than 6 in many of them.
Mhm.
And then the last few steps that you see, you're already high up, are happening in adulthood. I think that the message, and it was the same thing that we saw in the first natural history with Diana and Regalado paper. It's the same thing that we saw when we did a comprehensive progression of cerebrovascular disease in 2021. Diana also included her cohort there. And there's the same thing that we see over and over and over. The risk of stroke is really high in early childhood, but it doesn't go away because you become an adult. So it's not that you have, probably we will know that there's multi-peak time, but I don't think about it as the incidence is happening here, no longer there. I think they're all at risk. And there are multiple strokes, and the other factors why they don't continue to stroke. Some of them have already the brain is injured, so there is no other vessels to cause symptoms. So the strokes get diagnosed because you have neurological deficits. And when we did the study of the imaging, we found a lot more silent strokes than what the people reported clinically in the records. Okay, the brain is getting damaged, that is not giving symptoms, and that may go through the lifespan. We do know the highest risk is between 2.5, 3 years of age and 10.
I think the
So-
graph was a little hard because it's a cumulative risk
Yeah.
graphic,
Yeah.
it's not a relative risk graphic.
Yeah.
So cumulative risk graphic would grow over time, even if the incidence was at a young age.
yes, thank you for clarifying that, because
Yeah.
that sort of struck me as new information.
Yeah, we're not saying that,
Right.
yeah, it's not like by this age, you're definitely
It's
gonna have
exactly
a
the
stroke.
same. It looks exactly the same as in everything we've known so far.
Okay,
What I want the message to be clear is high risk of stroke appears to be in half of the patients, not all of them. There's another bias. The people that answer this survey, for whatever reason, they selected themselves to answer. So there might be the patients that are more aligned with the group and they're more neurologically affected and neurologists. There might be a lot of patients that have less involvement of the brain. In fact, we have collaborations with Baylor and Children's Texas Hospital to see if they really have any ACTA2 Arginine without cerebral disease, because it might be possible.
so as a follow-up to that, and I don't want to take us too off track, but as a parent, like all of us in this room, with children with this disease, is that even though that risk is not increasing, so to speak, say as they get older, but we do know that there has been patients that have passed away from strokes as a result of maybe it was just coincidental, but with infection Or, so I'm just wondering, as they get older, because some of these patients are now getting older, we have new patients coming in, we have young patients, and now we have patients like Avery and other kids that are getting older. Are there things we need to be thinking about because these kids are now going to become young adults and they're going off to college that they need to be thinking about when it comes to things like infections and things of that nature that can increase that risk?
I think the answer is complex and there might be time to address it tomorrow when I give some of the clinical recommendations. There is a session where we've been trying across the international community to get a consensus of what things people think we could be doing. But the stroke is multifactorial. So the vessels are narrow, that's the disease itself. And there are other thresholds that need to be crossed for the kid to become or the adult to become symptomatic. And almost in all the later strokes is event related. There is a blood loss, they stop the anticoagulation because they need to do surgery, there was a stroke, there was a surgery, and there was a stroke. There was a hypotensive event because of dehydration, there was a stroke. So we have a high suspicion that there is a composite of factors that lead to a symptom. And that's why we put all the emphasis on the care, is to try to be alert and then try to be preventive, whatever we can do. Infections cannot be prevented. Life should be lived, don't prevent life. So, and we call it shared risk management, okay? We discuss this with each family, with the patients as they become adults, and they can take their own risk. We have patients that are Olympic skiers, and which you say aortic risk should be doing, it's their life decision, okay? And there's many reasons why that is so good for them. So we don't get on the way, we say, well, this has risk. You have decide what risk you want to take. Okay, there are people that drive without seatbelts. But that's gonna come up in the clinical